significantly high in multiple resistances to antiretroviral treatments, including raltegravir or elvitegravir. And 68% had resistance to either one of these during the screening process. And really the levels of resistance were quite extensive. For example, 79% of participants had resistance to 2 or more NRTIs. 75% had resistance to 1 or more NNRTIs, and 70% had 2 or greater resistances to protease inhibitors. So in this study, dolutegravir twice daily was administered initially during the current failing antiretroviral regimen for the first 7 days, and then was optimized, with optimized background ART regimen on day 8. And I also wanted to note here that the baseline CD4 count was 140, and more than half had age-defining conditions. And then finally, they did a study comparing the strongest available protease inhibitor, darunavir, or otherwise known as Pozista, boosted with ritonavir in treatment-naive patients. And in the Flamingo study, participants were either given dolutegravir once daily or Pozista with an investigator-selected NRTI. And in this case, 75% of the investigators selected Truvada and 25% selected Pozista. And in this graph over here, really what we can see is that in terms of achieving an undetectable viral load, we could see that dolutegravir was superior in suppressing the virus against the comparator arm in all of the trials. So in a single study, essentially what was found is that at week 48, 88% of patients achieved undetectable viral loads compared with 81% in the triple arm. And subjects were also able to achieve faster virological suppression in the dolutegravir arm compared with a triplet. So although the purpose of the trial was to assess the non-inferiority of dolutegravir compared to triplet, for the first time ever, a drug, dolutegravir, has been shown to be clinically superior to efavirenz. While in most of the other studies we saw relatively similar gains in CD4 counts, dolutegravir was associated with a significantly larger gain in CD4s, 267 versus 208 in the triple arm. So now going to the Spring 2 study, we also see that at 48 weeks, 88% of patients in the dolutegravir arm were able to achieve undetectable viral loads compared with 85% in the raltegravir arm. And when we look at the CD4 count here below, we could see that both arms show the same gains in CD4 count at week 48, showing that dolutegravir is just as effective as raltegravir 400 milligrams in people who have never had treatment previously. In the saline study, overall, dolutegravir was shown to be statistically superior to raltegravir, with 71% over here achieving undetectable viral loads compared to 64% in the raltegravir arm. However, when we look at patients with greater than 50,000 copies, we could see a significant improvement, and we could see that dolutegravir performs significantly better than raltegravir, 62% versus 47%. In the Viking 3 trial, we also see that dolutegravir yielded undetectable viral loads at both week 24 and week 48 after the background regimen was optimized. So we see 69% undetectable viral load achieved and 56 at week 48. And while these rates are lower, they are important because they show improvement for people who have had a harder time finding an effective antiretroviral treatment. And finally, in the Flamingo trial, we see that 90% of people in the dolutegravir arm achieved undetectable viral levels, compared with 83% in the Persista arm. And the benefit was really seen for patients that had viral loads greater than 100,000 copies, and we can see here 93% achieved undetectable viral levels compared to Persista, where it was 70%. Now I'm going to talk a little bit about resistance. And the good thing here is that dolutegravir has shown to have really low incidence of resistance. And in almost all of the dolutegravir trials, it is shown to have no or minimal mutations. So in a single study here, for example, no one in the dolutegravir arm developed integrase or NRTI resistance mutations, while one person in the AAA arm developed an NRTI mutation, and 4 developed an NRTI resistance mutation. And we see the same sort of thing here in the Spring 2 trial, where there's also no evidence of treatment resistance in patients in the dolutegravir arm. And when we look at raltegravir, we could see that one person developed an integrase treatment emergent resistance, and 4 developed resistance to NRTIs. In the Viking study, we could see that although despite the presence of mutations, patients were still able to achieve undetectable levels. However, in terms of mutations, when somebody, sorry, apologize, my slide didn't move. So we could see here that the patients were able to achieve undetectable levels despite these mutations present. However, when the mutation Q148 over here is present, especially in combination with 2 or more secondary mutations, we see much less virologic success achieved at over here, 24%. What this may indicate is that dolutegravir may not be the best therapeutic option for patients with a Q148 mutation. Now I just wanted to take some time to talk about renal or kidney safety. And it's really important to sort of go over this a little bit and the importance of creatinine and how it affects kidney function. So essentially what creatinine is, it's a chemical waste that is produced from normal muscle breakdown. And generally what happens is the kidney is able to filter out most of the creatinine and disposes of it in the urine. And when there's elevated levels of creatinine in the body, this is often an indicator of kidney dysfunction or failure. So therefore, it's really important to measure how well the kidneys are able to filter and excrete creatinine. And So when we look at the dolutegravir trials, we can see that one thing that was common in all trials is, especially within the first 2 weeks, we see a slight rise in the level of creatinine, and then we see this stabilize over the next remaining weeks of the trials. And I think here the most important thing to remember is that dolutegravir doesn't affect the glomerular filtration rate, which really measures how well the kidneys are working and their ability to filter out this waste. And from these trials, we also found that this increase in creatinine did not cause any renal-related adverse events when using dolutegravir. So in terms of adverse events were very common amongst all trials, and the most common 3 were nausea, headache, and diarrhea. And in general, most of these adverse events were mild to moderate, and in most of the trials, too, dolutegravir had either a superior or similar safety profile when compared to the other drugs. So while headache, fatigue, and diarrhea were most commonly reported in most of the trials, in the single trial comparing dolutegravir to a tripla, we see here that insomnia only seems to be one of the most common reported events, and insomnia was only really noted to be very common in the single study, and really the reasons for this are unclear. But overall, dolutegravir did have a favorable safety profile compared to a tripla. And when we look at the percentage of participants who discontinued treatment due to adverse events, we see that in most studies, fewer discontinuations were seen in the dolutegravir arm compared to the other arms. And not surprisingly, the biggest difference here is seen in this single study, where only 2% of people in the dolutegravir arm discontinued treatment compared to 10% in the tripla arm. And the difference was mainly due to psychiatric or nervous system symptoms. So overall, in terms of the benefits that we've seen with dolutegravir and what we've learned today, that although dolutegravir isn't a single tablet regimen, it offers several advantages. So it's a simple dosing regimen, once daily, with really no regard to food or time of day. And we've seen from the clinical trials that it's well tolerated and efficacious. And it has a good safety profile, so it showed to have the superior, if not just as safe as other medications out there. The drug interactions have been minimal, and it could be administered to a wide variety of patients, so treatment naive, treatment experienced, and treatment resistant patients. And also there's the opportunity to individualize treatment. So patients could take dolutegravir, for example, with Krystexxa or Truvada as the backbone. So now I just wanted to open up the floor and see if there were any questions that anybody may have before moving forward. And just to remind you that you're going to ask a question, to raise click on the little man with the hand up, and once I address you, you can press unmute. You can unmute your line by pressing #6. Okay, Paul?
Thank you for this webinar. I think it's really awesome. I had an opportunity to meet with somebody from